So now we move on to the next presentation by Dr. Hardik Patel, our own student, now a colleague in the department. He is going to speak on post-transplant urinary tract infection, which was a part of his own thesis as well as rather dear to him. Very important topic. So Hardik, please go ahead. We can see your slide but can't hear you.
Hello, am I audible now?
You're audible now, yes.
And my screen is visible to everyone?
Yes, that is correct.
Okay. Okay, thank you. So brief overview of my talk would be, I will cover definitions as part of the Transplant Society, Infection Disease Society. I will talk briefly about asymptomatic bacteriuria, what are the risk factor and prevention, and then I will talk about our own data and experience of almost last 7 to 8 years of urinary tract infections. So large part of my talk will be from this article published in 2019 in the American Society of Transplantation Infectious Disease Community of Practice, and recommendations are also given very nicely in the this article. So those whosoever is interested should go through this article once. It is very nicely written and well covered. So coming to the definitions, the asymptomatic bacteria is defined as no symptoms, but the colony forming units for the particular organism should be more than 10⁵. And whenever we found this asymptomatic bacteria, the urine culture should be repeated one more time. And two consecutive culture showing similar organism is considered as a significant bacteriuria, especially with colony forming unit more than 10⁵. For a simple study, there has to be symptoms of urgency, dysuria, or pain, but there should not be any fever, and there should not be any indwelling device to call it as acute simple cystitis. Any infection with indwelling stents or a tube is considered as a complicated UTI. And there we can have a slightly reduce in the number of colony forming, where we can call it as a infection when even with a colony forming unit more than 10⁵ of particular uropathogens. For acute pyelonephritis, a complicated UTI, there has to be fever, chills, malaise, hemorrhagic instability, or a sepsis syndrome in the absence of other causes. And similarly, we have to have a urine showing pus cells more than 10 WBCs per high power field, and more than 10⁴ colony forming unit of per particular uropathogen. Uh, uh, about this diagnosis, certain organisms should not be considered as a urinary tract pathogens like Staphylococcus epidermis, Lactobacillus, and Gardnerella. Whenever these are grown in the culture, we should repeat the culture and see for the contamination. And another important thing is specimen collection. So all should be midstream specimen collection after cleaning of glands or private parts. In case of catheterized patient, if catheter is more than 2 weeks old, the catheter has to be changed and new sample has to be taken. Incidence. Coming to incidence, the prevalence is the range is very wide, and that is mainly because of different diagnostic criteria and different definition used by the different studies. And another thing is many centers have different prophylaxis regime, as well as and scientific practices are more prevalent when it comes to UTI. In Spanish registry, when there were more than 2,000 renal transplant recipients were followed up for 1 year. So maximum number of UTI episode happens during the first 6 months of post transplant, and in that registry it was almost 84% of patients develop UTI in first 6 months. So that again is it tells us that some of majority of the urinary infections could be hospital derived also. So coming to the risk factors, so the risk factors can be divided into non-transplant risk factors or typical transplant-related risk factors. In non-transplant, as we all know, female sex, diabetes, older age, previously bladder disease or a previous history of catheterization and previous history of UTI are all the regular risk factors for all patients. Particular transplant-related risk factors are presence of DJ stents, presence of reflux or a bladder disorder, patient developing rejections or receiving treatment for rejections, and or sometimes infection can be from the disease donor or a donor-derived infection can be there, especially in the cadaveric situation. And use of induction agent, although it is not known to cause a bacterial infection, but definitely there are enough studies which shows that ATG has more UTI compared to bacilleximab. And often missed and common less talk risk factor is local environment and the prevalence of MDR organisms in a particular hospital setup, which we do not focus or which is not published in the literature much. And that I will prove this by at the end of our end of my talk. What we commonly miss is clinical manifestation is standard like any other urinary tract infection, but I will like to mention that some of the transplant patient, because the kidneys are denervated, they may not develop graft tenderness. So graft tenderness is not a reliable sign. If a patient has fever, leukocytosis, hypotension, elevated creatinine, with or without urinary tract symptoms of urinary tract infection, only graft and absence of graft tenderness does not denote pyelonephritis. And their presentation could be graft dysfunction in the early post-transplant period without any symptoms, and that should be kept in mind in early transplant post-transplant period. Coming to antibiotic resistance, because all the now it's an era of MDR organisms, and all the prophylaxis which were used previously for urinary tract infection are not effective. Especially to mention the trimethoprim sulfamethoxazole, in the study from Netherlands, almost 83% of E. coli in the urine cultures were resistant to this commonly used molecule. So now it is no longer a urinary prophylaxis agent; it is more for a PCP. Now the word on the asymptomatic bacteriuria, whether to treat or not to treat. So routine treatment is not recommended. Treatment is recommended when there are two consecutive urine sample yield similar uropathogen in the first 2 months of the post-transplant. So two consecutive positive samples in initial 2 months, we can consider treatment, not always, and the treatment should be short duration of treatment. And in this kind of situation, we should wait for a culture reports to be available and choose narrowest spectrum available antibiotic, and not for more than 5 days to prevent development of antibiotic resistance. But again, advantage of this practice is not evidence proven, and that should be left to the treating physician. When not to treat is any asymptomatic bacteria beyond early transplant period should not be treated. There should not be any empirical antibiotic for asymptomatic bacteria. You should wait for a culture reports and you choose almost narrow spectrum antibiotic. Do not treat asymptomatic bacteria if second culture shows clearance of initial bacteriuria. So always two consecutive cultures should be there to even for treatment, and should not treat asymptomatic bacteria of MDR organism, especially because if you treat asymptomatic bacteriuria with higher drugs, then the subsequently development of resistance will lead to future failure of treatment. So should not MDR organisms of asymptomatic bacteria should not be treated. A word about asymptomatic candiduria. Again, it should not be treated because candida is a frequent colonizer of bladder, especially in person with ICU or indwelling catheters. It should be kept under observation because it has a high clearance rate, and should not be treated if it is asymptomatic. Only situation where it should be treated is if we are planning for procedures or patient is severely neutropenic. Regarding prevention, To prevent donor-derived infection, treatment should be directed against the pathogenic organism cultured in the urine of the donor and urine and blood. But it is mainly directed towards the disease donor programs where the patients are in ICU and with lines. If preservation fluid cultures are obtained and if there is any organism grown, then it should be treated accordingly. Like the trimethoprim sulfamethoxide, I already mentioned that it is now it is the resistance to this molecule is quite common and it is now no more urinary prophylaxis, but it is used for a PCP prophylaxis. If in certain group of patients where trimethoprim cannot be used for a prophylaxis of urinary tract infection, alternative agent can be used, but data is very limited, like nitrofurantoin, cephalosporin, and fluoroquinolones. But again, the fluoroquinolones, because of high resistance problem, should not be used, and these agents should be used only for initial few months, not more than 2 months. So even if we are using alternative agents, it should not be for for beyond 2 months of a post transplant period. Uh, these two initial things I have already covered. And another important thing is to minimize the catheter days as well as the indwelling stent days. That will significantly reduce the UTI episodes. But whenever we thought of a removal of early stents, we should also keep the in mind that increasing the risk of urology complication. So as far as all the studies are concerned, up to 2 weeks there are no significant increase in risk of infection. Beyond 2 weeks, the risk keeps on increasing. So up to 2 weeks there is hardly any difference whether we remove it early or not. So a word about ureteral stents, which is very much talked about whenever there is infection. So Cochrane review has found that urology complication are significantly decreased by putting stents, but again there is an increased risk of UTI. In the meta-analysis, it was not clear that stent increases the risk of the UTI. If we use the definition of symptomatic UTI, then there is not significant difference. But if we consider all the culture positivities, asymptomatic bacteriuria, then stents leads to increase the incidence of UTI. But if we see only symptomatic, then there is not significant. It is not significantly difference. Again, duration of stenting is also important. Any stents keeping beyond 2 weeks or increases the risk of urinary tract infection. So whenever the stents are there, there should be a balance between risk of urological complication versus infection. So coming to our own experience, the first when I joined, I was given a topic of nitrofurantoin randomized control trial for a post-transplant UTI. Then we tried a bedside commode. Then in 2019 we started to shift the patients from the transplant ward to special room, and then in 2019 we had a new transplant ward. I will come to each and every one in subsequent slides. And in between, we kept on trying the duration of DJ, duration of PUC, and DJ versus no DJ, PUC versus SPC. And what really worked, we'll come to know in subsequent slides. So first was nitrofurantoin prophylaxis randomized control trial, in which we use nitrofurantoin over and above trimethoprim sulfamethoxazole in randomized control trial for initial 3 months. And there was no significant difference between UTI, graft pyelonephritis, septicemia, hospitalization, or asymptomatic bacteriuria. So there was no significant difference in both the groups, and nitrofurantoin was not helpful in reducing the episode of UTI. The another reason for failure of this randomized control trial was because there was significant number of pseudomonal infections, which was prevalent in our transplant unit, and nitrofurantoin is not very much sensitive against the pseudomonal infections. So center with a high prevalence of E. coli, Klebsiella, it is we can certainly think about using nitrofurantoin, but centers like our where the pseudomonal infection rates are very high, it is not worthy molecule. And another conclusion from the another finding from the study was that PUC, SPC, and DJ duration was significantly associated with increased rate of urinary infections, and it should not be used in a center with a high prevalence of pseudomonal infection. Then because this failed, we tried using beds, because we in our transplant ward we had a common toilet and bathroom for patients. So we tried using a bedside commode for each and every patient. Uh, and initial results were quite promising. Study group had a significantly lower UTI, so lower bacteriuria, and fewer number of UTI episodes. But subsequently over the time again this also failed. Then we tried different strategies for a catheter days and DJ removal days, but again that also did not help us much. We also tried to put doing PUC versus SPCs. Again, there was not much of difference between symptomatic UTI. Obviously, there was some reduction in asymptomatic bacteriuria, but there was not much difference between symptomatic UTI with SPC. In fact, it was the number was slightly on higher side with SPC. So finally, what we started doing is we started shifting the patients immediately after transplant to the special ward till we had our new transplant ward, which was which now is functional, and it has separate cabin and separate toilet and bathroom for each and every patients. So you can see the after this shifting and new ward is in action. Out of 121 patient, only 10 developed urinary infection, and out of even these 10, nine infections were only two had a symptomatic UTI, 8 were had a mild symptoms, and which were treated with a commonly used drugs and for a short duration of time. Compared to previously, what we had, I had a 131 patient, out of 131, 43 had a UTI. And at that time, we even calculated the cost of a single episode, which was coming around 1.5 lakhs with because of MDR organisms which were prevalent. So with this strategy, only separate toilet, separate bathroom, and isolating the patients, now the UTI rates are in very much control. So as I told you, the risk factor which we never talk, and as also initially elaborated by the Dr. Rajapurkar sir, was that whenever we break the protocols, then we start getting infections. So after the new ward building has been is there, we are quite happy, and the patients are also happy with a significant reduction in the UTI episodes. So to conclude my talk, the prevention is the only way forward, because no oral prophylaxis are effective in today's time, and treatment of asymptomatic bacteriuria should be limited to the certain group of patients only. Thank you.
Thank you, Hardik, for a very nice presentation.